Today's episode of the Stallside Podcast was brought to you by Rood&Riddle Veterinary Pharmacy.
Bart, how you doing today?
Well, I'm better today. It's good to have you back in the room.
Yeah, they actually gave me the keys to the asylum and I let myself out.
Well, glad we captured you and brought you back in.
Yeah, you want to see what I left behind. So, interesting guest on the show tonight.
Very interesting. You know, a veterinarian that came along about the same time that I did, been with us a long time, but takes a very different approach to veterinary medicine, and I'm interested to talk to him.
Yeah, when I first dealt with Chris, he was sort of like in sort of mixed practice, right? He did a lot of broodmare work and he had some sportable stuff on the side, but his practice sort of shifted and his location shifted, and he's sort of full-time into that now, and he has a very interesting approach to pain in horses and how to manage that.
He does, and a lot of what he does as a veterinarian is his observations as a horseman. So he's got a very different approach.
Yeah, that's true. And there has been a lot of work on that just recently and how horses respond to pain and how that may be responsible for some of the performance limitations that we see them display.
Yep.
So on stall side, this episode, we're talking to Dr. Chris Newton from Rood&Riddle Equine Hospital about his approach to the painful horse, how it may affect their performance, and what therapeutics he applies to them to get the best out of them. Chris, welcome to Stallside.
Hello. Good evening.
Yeah, thanks for taking your time out of your day to be with us. Appreciate it.
Absolutely. It was a quick drive up here from Florida to do such.
Yeah, okay. Hey, Chris, tell us a bit about yourself.
Let's see. I am probably one of the few local grower-uppers in the group. I was not born in Lexington. I was born in New York City, but moved to Lexington when I was 5 years old. And my parents had absolutely nothing to do with horses. My dad bought a farm as a real estate investment, and I talked them into buying my first pony for $100, and always wanted to be a cowboy. Then went to the 1978 World Championships, which was at the horse park, and became an avid eventing fan and full equestrian addict, basically at that stage of the game, from which I competed professionally quite a bit, and then decided I needed to find a way to make money when I started a family. So I went to vet school and had worked for Rood&Riddle basically from the time of its inception. The founders, Dr. Rood, Dr. Riddle, Dr. Embertson, all came out and treated colics and looked at emergencies and lacerations on my horses at the farm in the very beginning days, and really inspired me at that point in time to become educated and join a practice of exceptional individuals, which I did in 2000. I took a year and a half out of school, went to Charlotte to practice before coming back, just because I didn't want to be so insular and only see Lexington, and then have been here pretty much since, and started out in a combination of general broodmare, thoroughbred practice, farm practice with sports medicine. At that time when I came, Dr. Rood was excited about starting sport horse stuff, and Dr. Pierce said, we'll never have a sport horse client probably in the time of this practice. And we've seen that shift dramatically as we've grown through the years.
Threw Dr. Pierce right under the bus, didn't you?
Never say never again.
Exactly.
Work for Sean Connery.
And then I kind of retired from sport horse practice, or from broodmare practice, in 2015, and have concentrated just on sport horses and gotten back into competing and eventing pretty heavily myself. Last year, I was the Masters advanced level and intermediate level champion for the United States in eventing, and I'm shooting to break the record at the largest three-day event in the country, the horse park, this spring, in the time span between competitive rides there of 33 years.
Wow.
So
ambitious.
Wow.
Yeah.
And that's one thing we know about Chris. He's ambitious. Yeah. I knew you were born in New York City. That's a new fact for me.
Yeah.
So, one of the first, it wasn't the very first case that I did, but it was one of the first 3 or 4 anyway. I looked at a horse for your mom, Nancy. And that was, we got a call here, and they sent me out there, and I got to know your mom pretty well.
Yeah.
In the few, in that few years when she was still around, and it was great. Your family was a big part of Lexington for sure.
Yeah, we have it's been wonderful. Well, Lexington's a wonderful area, that's for certain.
But you split your practice between Lexington and Ocala. So tell us a little bit about what your day looks like.
I try to get up first thing in the morning and ride 2 horses because you have to ride in order to compete at that level now. And then I'm practicing, seeing lamenesses and still do some emergency work. Eyes and colics, you don't avoid that for the clients that I have. I do a lot of body work. I really, prior to going to veterinary school, I felt like horses' bodies, just like human bodies, tended to be a primary source of pain. But at that point in time, I would have a vet look at a competition horse, and they'd say, "Well, it's sound. There's not a problem. Wouldn't worry about it." But the way they performed, they were definitely exhibiting pain behaviors in the way that they went. That was, at that point in time, was kind of the advent of equine acupuncture with Dr. Kane, and I traveled with him for a while, and equine chiropractic started to come out, and I studied that for a while and integrated that into my practice. Still was doing a lot of joint injections, and now I've transitioned a lot more towards treating spinal nerve pain and developed a rehabilitational techniques which are based off classical dressage training, more like you would do in physical therapy in humans, where we exercise horses in manners repetitively to regain strength and range of motion to regions of the body that are not they're not utilizing and they're compensating away from. And the degree of pain that a lot of horses have in their body is shocking to me, and still the identification of that pain by many of us in the equine world, although growing significantly over the last 5 years, is being missed, I think.
Well, let's talk about that just a little bit, because you talked about pain behavior, and that's I'm guessing that's not the objective pain that we see exhibited in lameness or
correct
or something like that. So could you dive us into a little bit further into that? What you mean by pain behavior?
Lots of both performance and behavioral problems. Horses that rear, I find, generally have extreme pain at the atlanto-occipital or the first spinal nerve region. They don't want to come through contact. And horses that are swapping leads as they're working, horses that are resistant to go forward, horses even that stop jumping, that have wanted to perform and jump, oftentimes prior to exhibiting unsoundness, will exhibit these behaviors and then push through it, or horses that are just so determined to succeed for their owners that push through it will begin to compensate, hyperload certain limbs, and then we start seeing the soft tissue and the articular pain that is our classic objective pain with gait irregularities and lamenesses that we can block out. But there's a whole group of asymmetries in gait and irregularities in behavior and performance that come far before we're able to block out or isolate a lameness to a limb, to the degree that I think hoof growth is oftentimes correlated with the hyperloading. So you'll see one heel that tends to be very low, one leg that's very high. And that really, in my opinion, comes from spinal nerve compression and compensation and hyperloading of one side versus the other long term, because we see them as foals, as brand new day-old foals, and they don't have a high-low foot. But within a 60-day to 90-day period, you start to see growth patterns that are associated with that. And I actually think that comes from spinal nerve compression during the parturition process that they initially start to compensate for, which surprised me, because as I was initially sorting this out, I was wondering what it was about our training techniques that was creating this issue. And so I went to palpate day-old foals and palpated about 60 of them, because I was still doing reproductive practice at that time. And about 9 out of 10 of those foals exhibited significant pain in similar areas as the adult horses that I was looking at for performance issues at that time.
Yeah, something that's sort of been in the sort of the equine literature at the moment is the ridden horse pain ethogram, sort of driven by Sue Dyson. You'd like to comment on how that fits into what you see? Yeah,
I think it correlates very highly, although Sue tends to look a little bit more and is coming more towards spinal pain, but still is more articular in her viewpoints. But the ethos is that their behavior most often is associated with pain or pain that is elicited when they respond to you asking them to do something. So even something as simple as you taking a hose to hose a horse off and it inverts and throws its head up in the air, if it has pain in that first region around the pole, it's like whiplashing it. And it will immediately start to correlate hosing with that pain because it's eliciting it, and you will start to develop a cycle of behavioral patterns that you have to retrain the behavioral patterns, but until you start taking the pain away, it's very difficult to retrain those behavioral patterns.
So you mentioned about taking the pain away. I mean, there's systemic medications, there's probably some targeted local things that can be done. You mentioned acupuncture before. What's your approach to these horses that start to develop this aversion to exercise before they actually show overt lameness?
So unfortunately, we're still lacking in significant neurodiagnostics of the body of the horse. And a lot of it goes back to clinical palpation and experience for me, which makes it hard to publish on and things like that. But it's pretty simple, really, to palpate a horse and identify where the pain is. They will tell you pretty well where it is. And I tend to go where that pain is, and I will remove it utilizing primarily a local anesthetic along with a drug called Serapin that is a alkaloid that helps to block the C fiber pain or diminish it by a bit for a period of time. And what surprises me is that doesn't last for 2 hours, but it sort of allows that neuromuscular reset to occur and they relax. But that's not the fix. If you do that, or if you do pulsating electromagnetic therapy or any of those, you can eliminate a certain degree of pain. And with this method, I've been able to eliminate 100% of the pain, whereas with acupuncture and PEMF, I was only able to eliminate about 20% of the pain. So really painful horses, I couldn't make a big difference in. And the real change is you have to begin to work them in a manner that they change. They have to go to Pilates, basically is what you have to do, Pilates, and they have to change their core. And because horses are quadrupeds, they don't have to change a single area of our core like a human would. As humans, you go to Pilates and you work on a negative pelvic angle. Michigan State's done a lot of research in runners showing that the negative pelvic angle improves long-term soundness in human runners as well as long-term performance. But if you bring the top of your pelvis back, you naturally curve your spine into a mild C, similar to what you have when you are developing in your mother's uterus, which every other mammal has. And what I find is wherever the spine starts to dip towards the front excessively, it begins to put pressure on those nerves, and that pain cycle begins to start, and then the body starts to guard, and you can't begin to change the core musculature. And again, in horses, the two cores versus the one, we have to change both the shoulder or the shoulder sling musculature as a core and the abdominal musculature as a core. So they have to be able to both lift their withers, their entire back, and tilt their pelvis while the head is being carried. And the problem is if you lift the head quickly with the withers being trapped down, they will develop pain quickly. It's very fast, and you want to modify that, and they'll oftentimes then revert into this pain ethos where they start having behavioral problems. And the first thing that typically happens is you check the saddle fit, and you change the saddle fit, and it improves them for a period of time because the pressure points are slightly adjusted. And then you begin to blame the farrier. That's usually the next individual that gets thrown under the bus. And the farrier is generally saying, well, every time I go to pick this horse's legs up, he's going into spasm and is hating it. And to me, that is because you're engaging these neural pathways that are already in pain. And the load in the foot is being affected by the compensatory load from the body pain. And so they're reflecting it in growth patterns, oftentimes shearing heels and things like that. And so the farrier is trying to support that, but they can only do it so much, because if you're not changing load, you're not really changing balance that much of the foot, and it's not going to change. So in my opinion, you have to both help the foot as well as help the body simultaneously.
So you mentioned a little bit about how the horse orientates itself under the influence of the rider. So what particular positions can a rider put a horse in which will actually lead to the problems that you see? Bringing the head in,
Well, horses have three basic disobediences when it comes to handling them. One is overpowering, going forward, backwards, or sideways, right? They're going to overpower, run forward, sideways, or backwards. Another significant inversion or misbehavior is inversion, where the head comes up and the back drops. And the third primary disobedience is they will freeze in their front legs, something in that the French term is accouplement, or free or stillness of the hands, and they won't move. And that's probably the most dangerous. The inversion and accouplement lead to the rear, and the rear behaviorally is the most dangerous misbehavior that a horse can do under saddle for a rider, because of the potential of them falling on them. And I could count probably 8 clients that I've had that have been killed by horses rearing and flipping over on them during my time working as a veterinarian, and maybe a bit before as a rider also. But those disobediences naturally lead to this freezing, and oftentimes the inversion is used to help gain control because it's painful, right? And you can invert a horse in order to stop it if it's overpowering. But the problem is then they start to learn that behavior, and you start changing the muscles. And in my opinion, we have to get the horse to go more into that fetal shape that they developed in, not severely and not in a forceful way. And that's why you have to take the pain away, but in a manner that they start to develop those core muscles that lift the spine and put it back into that full mild C shape. And then the horses will be free of pain. For instance, the horse that I'm trying to get to Kentucky this year was given to me 5 years ago because he was unrideable, purchased for quite a bit in Europe, and diagnosed with EPM, diagnosed with cervical issues. And over a period of time of removing pain and retraining and kind of going through the process of figuring it out, he's gotten better and better, and he hasn't had to be treated for quite a while because now he's strong and uses his body correctly, right? Which is the whole concept of true physical therapy in humans, right? Our goal is to, oftentimes our injuries occur. If you're a pitcher, your injuries occur to your arm typically because your technique is not correct, or your musculature can't support the technique that you're using to throw certain styles of balls. And there's tremendous research in young athletes showing that multi-sport athletes tend to have fewer career-ending injuries than single sport athletes, with baseball actually being the primary single sport damaging athlete that there is. And that's, in my opinion, because you are strengthening multiple muscles and you're never putting tremendous strain on a single group of muscles all the time. And we get sometimes fixed. And as we've moved further and further away from the cavalry in the world, where these techniques were used to train horses, and they were passed down by generations. And the first people that taught me were generals and colonels, General Burton and individuals like that. But that's been lost, and we've lost a lot of those older techniques, and they've been passed on to quicker, more efficient and better breeding techniques. So we breed for these super athletes, which we're getting oftentimes, but we aren't spending the time to develop them earlier in their lives such that they aren't affected by the time that they're 8 or 10 with these pain, behavior, and then lameness consequences of it.
You mentioned about palpating for your exam. So if you're approaching a horse like this, say one of these horses that was going rigid in front, lifting the head back and trying to rear, what would be your approach to that horse? You say you palpate, you're obviously going to look at the horse. How does Chris Newton assess those horses?
The first thing I do is I watch the horses in motion, and I'll either watch them on a lunge. I tend to watch them all on a lunge, not typically on a paved surface, because I find paved surfaces to be quite slick with shoes, and they really compensate in their gaits for that, so it's unfair. And there are two things I'm looking for. I want to see if a horse, independent of themselves or independent of a rider, will go around and put their head all the way to the ground and lift their back. And it is shocking to me the number of horses that you can put on a lunge and trot and canter. The walk most will, but the more you push a horse forward, the more it engages the hind end. And the horse's back muscles are interconnected with the gluteal muscles, which is different than the human. And thus, as the hind end engages, it forces the back to stretch. And horses will refuse to go forward, or they will refuse then to put the head down as they go forward, because if they put the head down and stretch, they have to lift the back. And I would say 7 out of 10 horses that I put on a lunge, free of themselves, would go around the circle for 5 hours and never put their poll below their withers, never stretch the poll below their withers. Now, they'll do it when they're grazing, but when you watch them graze, those ones that are really affected will split their front limbs severely. They'll put one front limb out much further than the other. And a horse that has less pain will stand much squarer in front. And that's why the square halt of dressage, which dressage was developed from military training techniques, is what is evaluated at the halt, that the horse stands up with all 4 legs there, because a horse that stands unsquare is oftentimes unwilling to stand evenly on both legs, because they have some degree of compensation. So I'll watch them go free like that, and then I'll flex their joints and see if their joints and soft tissue is a source of pain, which if it is, then I can't do the rehabilitation of the body. We have to deal with the joint or the soft tissue injury. We're not going to take a horse, for instance, that's just torn a tendon and treat its body and put it into work immediately. It's got to heal the tendon. Then I say, why did it injure the tendon? Was it just a primary stepped in a hole, or is it an overload injury, which I think most often it is? And most often I will correlate that with pain up high, and then I'll do palpation all the way along the spine, palpating for neuromuscular pain, and it's pretty easy to elicit once you figure out where to palpate. And it's shocking. There are horses that the reason I now palpate that last is because there are horses that when I hit those points, they won't allow me near them again to touch them. It's so painful. And it shocked me when I first started to sort that out. And now it doesn't shock me at all. It makes sense because people are the same. You know, there are lots of people that you go up to and you go to hug them or something. They say, "Don't touch me." And you say, "Is your back painful?" And they'll say, "No, my back's not painful." But then they'll walk away and hunker and they can't pick anything up off the floor. And, you know, our ability to survive, we have natural abilities to reduce our pain thresholds and to fool ourselves into thinking we're not in pain. But we are.
Right. So once you've actually identified that focus of the pain, you mentioned some medications before. What's your approach?
I will, if the joints are good, then I will inject around where the nerves are coming out of the spine, around the transverse process with the combination of carbocaine, serapin, and a little bit of prednisone. It's not a primary steroid based. I use just a little bit that lasts for 12 hours to stop inflammation at the site. And they begin working the next day. And they begin the rehab process the next day. If the horse is really inversive, I begin to teach the clients the techniques. And if they're capable of doing it, they'll do it. If they're not, then I'll set up with a trainer or ourselves to help them do the rehab in the beginning. And we begin to work the horse in hand without a rider on, because typically the upper back is the area that's the most affected to the lower neck. That's the most naturally downward bending region of the horse. And we want to lift that. And that's a very difficult area to get a horse to lift. And with just a little bit of weight, as a rider, it affects it. If I just put my hand on those horses when they're in pain, most often they will rear or they will try and fall to the ground rather than lift their wither without a rider on them. And so we keep the rider off until they learn how to go posturally correctly. And we also work on balance so that they learn to carry their balance on the outside shoulder, because as a horse goes around a turn and they fall on their inside shoulder, they have to engage the back muscles and hold them tightly. And you'll see horses going around. Early on, I would see horses that were lame on the right front. I'd get horses that were non-responsive to everything for, say, a right front lameness, and I'd put them on the lunge line, and they would go around with their haunches into the circle at around a 40-degree angle, bent to the outside, severely hyperloading their lame leg, right? The leg that hurt them. Well, if a horse steps on my right foot, I hyperload my left. I hobble around and don't put weight on that. And I said, that's why I walk down the pathway that I think oftentimes it is secondary to that compensation. And as I oftentimes could just treat the body and change how they carried themselves, and the lameness would dissipate and go away without even treating specifically that area in the heel. Oftentimes it was sore and things along those lines, which shocked me. But it's a process. It's not, there's no magic to it. It's if you want your back to get better, and you go and get an epidural injection, and you don't go and start doing physical therapy and Pilates, you will never get better. It will continue to be an issue. If you begin to change your posture and you strengthen around your core, you will begin to improve. And the same thing can happen in horses. The problem is they're so big that you have to understand more effectively how to do it. And, we oftentimes just put them in swimming pools and things like that as rehab. But I think it has to be a work-based learning self-carriage correctly process.
And that is an uphill battle, because we live in this 30-second TikTok world where people want you to inject something and be done with it and move on. So so what you're describing is much more of a process. It's learning. There's a learning curve to it, and an education that people need to go through.
Yeah, absolutely.
Yeah, there's no quick fixes here. Give us an example of a case, of course not naming names, recently where you saw a particular behavior and you set in motion certain remedial activities, and what the time course of that was.
Let's say I had a horse that competed at the RRP that won this year, who in May was rearing and had been diagnosed with severe kissing spine and a left hind high suspensory pain. There was no ultrasonographic change to the suspensory ligament, and they were told that the horse needed to likely be euthanized because kissing spine surgery probably had about 10 dorsal spinous processes that had enthesiophysic activity and some remodeling on them. And they said probably it's going to cost quite a bit of money for the surgery, and the likelihood of a positive outcome isn't very high. And they found me through another client and came, and we began that process. The left hind high suspensory pain was really a radiating sciatic nerve pain. It was a left hind dominant horse, which most horses are left hind dominant, unlike humans, which are right hand dominant. And the horse tended to rear, buck severely, and had developed a splint on the inside of the right front where it also hyperloaded, and it had gone through some stall rests and become basically angry at the world and was biting and being somewhat nasty and vicious. And so we began this process with that horse, and we trained it for a while because he was so difficult. And then the owner took over, and it went on to do quite well at the Retired Racehorse Project. And she's since now down in Florida competing this winter with the horse, and the horse has been sound. And we still do the work, right? Before she gets on him every day, he goes on the line and has to carry himself correctly in self-carriage. Because when we ride a horse, we compensate for their imbalances, and they have to learn to compensate for their imbalances themselves. And that type of case has repeated itself over and over for me, even, with my own horses I was talking about.
You mentioned earlier some of the difficulties because we don't have the right diagnostics. Any hope on the horizon for new diagnostics that'll help you out?
I asked Dr. Garrett. There is a new muscle device that measures pressures, which is being used for high suspensories. Ken Allen published a paper looking at high suspensory injuries using this, but it is very correlative to my palpation techniques, meaning I've messed with the people that are selling it, but it wasn't able to give me significantly more than what I was garnering from palpation. And for the price line that we went in, I didn't think it was worth that, but I hope so. Yeah. When I talked to Dr. Garrett, because I wanted to do some studies looking at horses in different training positions and doing CT of the spine or x-rays of the spine. And she said, we just can't get those images. And the problem is we don't have humans that are large enough yet to drive the economy to get those there. But hopefully, everybody, I think, as the industry recognizes more and more, and from the point in time that I started looking at bodies and everybody else thought it was crazy, to now it has shifted tremendously. And my hope is that we do get more and more. I get radiographs now. We didn't, before the advent of the digital x-ray machine, we didn't diagnose kissing spine. It was never heard of. And in my opinion, kissing spine is a symptom. It's not a cause. But as soon as we started having widespread diagnostic digital radiography, all the horses had kissing spine, and it's a big banter. And now we're seeing that with the lower cervical vertebrae and the cervical vertebral malformation. And I think that we have still a lot to learn. We don't have a lot of pain relieving, minimally invasive surgeries around the spine that humans have, which I hope will begin to be developed, like photoablation therapy and things like that. And it's just people, I think the next generation will pursue it more because it is very relevant to performance. And I think by 2 generations of veterinarians, we'll begin to see significantly more intervention as well as diagnostics.
Yeah, and there's a lot of change on the horizon. Just we learn so much more all the time.
Yes, it's got a lot more complicated, hasn't it?
It has. Yeah.
Yeah. Well, that's great. Chris, thanks for coming in and seeing us. This is a very holistic approach to the horse, right? It's not just a case of trying to localize something and block it out. It's a case of sort of like looking at the horse as a whole and saying, okay, we temporarily relieve this pain, and then we train you out of the pain, right? Because you can only take so much medication for these things before you're not really solving the problem. So this is a really fascinating approach.
Yeah, I agree. Thanks for being with us. That's interesting.
Absolutely. Yeah. Thank you, guys.
Yeah.
Wonderful.
Yeah. And that was Stall Side for this week. We were talking to Dr. Chris Newton regarding his approach to pain in horses, the performance effects, and how he holistically looks at the horse to deal with that. See you next time.